रब्बी शरहली सदरी व यस्सिरली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली। अल्लाहुम्मा इन्नी अस्अलुका इल्मन नाफ़िअन रिज़्क़न तय्यिबन व अमलन मुतक़ब्बला शिफ़ा मिन कुल्ली दा। Topic of discussion is presentation and management of vaginal pathologies. This is Dr. Zunaira Faiz. I just want to throw a little light on this female reproductive system before starting the topic. The narrow neck of the uterus is called the cervix. Situated at the bottom of the uterus, the cervix normally acts as a barrier, preventing bacteria and viruses from traveling from vagina into uterus. Ecosystem in vagina: estrogen, pH in vagina 3.5 to 4, vaginal flora, lactobacilli, acidogenic Corynebacteria. Benign vaginal lesion: Bartholin duct cyst and abscess. Causes: obstruction of the main duct of Bartholin's gland result in retention of secretion and cystic dilatation. Cause of obstruction: infection, inspissated mucus, congenital narrowing of the duct. Bartholin duct cyst and abscess. Sign and symptoms: some of them have no symptoms. Once the abscess formed, patient will feel pain, tenderness and dyspareunia. Dyspareunia is the painful coitus. It can be superficial dyspareunia or it can be deep dyspareunia. Surrounding tissues become edematous and inflamed. Fluctuant tender mass is usually palpable. Treatment of the Bartholin duct cyst and abscess: drainage of infected cyst or abscess, antibiotics. Excision of the cyst may be required in recurrent cases. Symptoms of vaginitis: abnormal vaginal discharge, pruritus, itching, burning, soreness, odor, dyspareunia, bleeding and dysuria. Painful micturition. Atrophic vaginitis: prepubertal, lactating, postmenopausal, reduced endogenous estrogen, causing thinning of vaginal epithelium susceptible to trauma and infection, pH high. Patient complaints: genital and urinary complaints. Genital: dryness and itching, burning, dyspareunia, vulvar, that is vulvar pruritus, feeling of pressure, yellow malodorous discharge, spotting, irritation and tear. It can be, there is maybe feeling of small abrasion. Urinary: dysuria, painful micturition, frequency of micturition and blood in the urine. Urinary tract infection, stress incontinence, that is, there is a dribbling of the urine when the patient laughs or cough or change of posture or lift heavy weight. You can see in this picture. Treatment for atrophic vaginitis: treat with estrogen replacement, vaginal or oral, and then oral ethinyl estradiol up to 50 microgram, conjugated estrogen up to 1.25 mg in combination with medroxyprogesterone acetate to prevent endometrial hyperplasia. Vaginal cream 1 gram daily for 1 month, 4 times, and then half dose for 2 weeks, 1 gram vaginal cream, 0.625 mg conjugated estrogen. Should give with 2.5 milligram medroxyprogesterone for 14 days. Estrogen vaginal ring, change after every 3 months. Estring, delivers 6 to 9 microgram estradiol daily. Vagifem 1 tablet intravaginally for 2 weeks, then 3 weeks for 3 to 6 months. Diseases characterized by vaginal discharge: vaginitis is usually characterized by a vaginal discharge and or vulvar itching and irritation, and a vaginal odor might be present. The 3 diseases most frequently associated with vaginal discharge are bacterial vaginosis, trichomonas, candidiasis. Various diagnostic methods they are available to identify the etiology of an abnormal vaginal discharge. The cause of vaginal symptoms usually can be determined by pH and microscopic examination of fresh samples of the discharge. Laboratory testing fails to identify the cause of vaginitis in a minority of symptoms and the minority of women. Bacterial vaginosis, BV, is the name of a condition in women where the normal balance of the bacteria in the vagina is disrupted and replaced by an overgrowth of certain bacteria. It is sometimes accompanied by discharge, odor, pain, itching, or burning. Bacterial vaginosis. Homogeneous thin white discharge, as you can see in this picture. Bacterial vaginosis (BV) is a polymicrobial clinical syndrome resulting from replacement of the normal hydrogen peroxide producing lactobacillus, especially in the vagina, with high concentration of the anaerobic bacteria. For example, Prevotella species and Mobilincus species, Gardnerella vaginalis and Mycoplasma hominis. Diagnostic considerations of the bacterial vaginosis (BV) can be diagnosed by the use of clinical criteria or gram stain. Clinical criteria require 3 of the following symptoms or signs. Number 1. Homogeneous thin white discharge that smoothly coats the vaginal wall. Presence of clue cells, epithelial cells with borders obscured by small bacteria on microscopic examination. pH of vaginal fluid more than 4.5 and a fishy odor of vaginal discharge before or after addition of 10% potassium hydroxide, that is the VIF test. When a gram stain is used, determining the relative concentration of the lactobacilli, long gram-positive rods, gram-negative and gram-variable rods and cocci, that is Gardnerella vaginalis, Prevotella, Porphyromonas and Peptostreptococci, and curved gram-negative rods, Mobilincus. Culture of the Gardnerella vaginalis is not recommended as a diagnostic tool because it is not specific. Bacterial vaginosis, as you see in this picture, here obtaining a sample of a discharge, cervix, vagina, rectum, bladder, swab, speculum and uterus. Here you can see that how the swab is taken. First we introduce the cuspospeculum and then we take the swab. This is VIF test. Treatment of the bacterial vaginosis. A woman who have symptomatic disease require treatment. Recommended regimes for non-pregnant women: metronidazole 500 mg orally twice a day for 7 days, or metronidazole gel 0.75%, 1 full applicator 5 gram intravaginally once a day for 5 days, or clindamycin cream 2%, 1 full applicator 5 gram intravaginally at bedtime for 7 days. Follow-up visits, they are unnecessary if symptoms resolve. Because recurrence of BV is not unusual, women should be advised to return for additional therapy if symptoms recur. Management of the sex partners. The results of clinical trials indicate that a woman's response to therapy and the likelihood of replace or recurrence, they are not affected by treatment of her sex partners. Therefore, routine treatment of sex partners is not recommended. All pregnant women who have symptomatic disease require treatment. Recommended regime for pregnant women: metronidazole 250 mg orally 3 times a day for 7 days, or clindamycin 300 mg orally twice a day for 7 days. We should do the follow-up of pregnant women. Treatment of BV is in asymptomatic pregnant women who are at high risk for the preterm delivery might prevent adverse pregnancy outcomes. Therefore, a follow-up evaluation 1 month after completion of treatment should be considered to evaluate whether therapy was effective. Trichomonas Vaginitis. Now, it is caused by protozoan Trichomonas Vaginalis. Many infected women, they have symptoms characterized by a diffuse malodorous yellow-green vaginal discharge with vulvar irritation. However, some women have minimal or no symptoms. Now, note the frothy discharge seen around the cervix in this picture. Signs and symptoms. About 50% of the women infected with Trichomonas do not have symptoms. The severity of discomfort varies greatly from woman to woman and from time to time in the same woman. Symptoms can be worse during pregnancy or right before or after a menstrual period. Principal symptom: persistent vaginal discharge, profuse, extremely frothy, greenish, foul smelling, vaginal itching, irritation, and pain, patchy redness of the genitals, including labia and vagina, frequent painful dysuria if urine touches inflamed tissue, generalized vaginal erythema with multiple small petechia. Diagnostic considerations. Trichomonas vaginitis. It is diagnosed when we perform microscopy of the vaginal secretions, but this method has a sensitivity of only approximately 60-70% and requires immediate evaluation of wet preparation slide for optimal results. Culture is the most sensitive and specific commercially available method of diagnosis. In women in whom trichomoniasis is suspected but not confirmed by microscopy, vaginal secretions should be cultured for Trichomonas vaginalis. DNA probe test, which detects genetic material (DNA) of the Trichomonas organism. This test is rarely needed to identify Trichomonas and is usually available only in research studies. Recommended regime for the treatment is metronidazole 2 gram orally in a single dose, trinidazole 2 gram orally in a single dose. The cure rate in treating trichomonas using oral metronidazole is 90% to 95%. In resistant cases, oral metronidazole may be repeated after 4 to 6 weeks. Alternative regime: metronidazole 500 mg orally twice a day for 7 days. Follow. It is unnecessary for the men and women who become asymptomatic after treatment or who are initially asymptomatic. Management of sex partners. Sex partners of the patients with Trichomonas vaginalis should be treated. Patients should be instructed to avoid sex until they and their sex partners are cured. Now, special considerations. In pregnancy, vaginal trichomoniasis have been associated with adverse pregnancy outcomes, particularly premature rupture of the membranes, preterm delivery, and low birth weight. However, data do not suggest that metronidazole treatment results in a reduction in perinatal morbidity. Women may be treated with 2 grams of the metronidazole in a single dose. Metronidazole is pregnancy category B. Animal studies they have revealed no evidence of harm to the fetus, but no adequate, well-controlled studies among pregnant women have been conducted. Vulvovaginal candidiasis is caused by Candida albicans, but occasionally is caused by other Candida species or yeast. An estimated 75% of the women will have at least one episode of vulvovaginal candidiasis. 40 to 45% will have 2 or more episodes. On the basis of clinical presentation, microbiology, host factors, and response to therapy, VVC can be classified as either uncomplicated or complicated. Approximately 10 to 20% of the women will have complicated VVC, suggesting diagnostic and therapeutic consideration. Now, you can see in this picture, typical symptoms of the VVC, vulvovaginal candidiasis, include pruritus, vaginal soreness, dyspareunia, external dysuria. None of these symptoms is specific for VVC. Abnormal vaginal discharge, white curd-like cheesy vaginal discharge. Uncomplicated VVC, sporadic or infrequent VVC, mild to moderate VVC, likely to be Candida albicans. Non-immunocompromised women, complicated VVC, recurrent, severe, vulvovaginal candidiasis. Non-albicans candidiasis, women with uncontrolled diabetes, debilitation, or are immunosuppression, or those who are pregnant. Uncomplicated VVC, diagnostic consideration in uncomplicated VVC based on number 1, clinical features, external dysuria and vulvar pruritus, pain, swelling, and redness. Signs include vulvar edema, fissures, excoriations, or thick curdy vaginal discharge, demonstrations of candidal mycelia, either number 1, a wet preparation, saline 10% potassium hydroxide, or gram stain of the vaginal discharge demonstrates yeast or pseudo-hyphae, or 2, a culture or other test yields a positive result for a yeast species. Number 3 is the normal vaginal pH less than 4.5. Treatment for uncomplicated VVC. Short course topical formulations, that is single dose and regime of 1 to 3 days, effectively treat uncomplicated VVC. The topically applied azole drugs are more effective than nystatin. Treatment with azoles result in a relief of symptoms and negative cultures in 80 to 90% of the patients who complete therapy. Recommended regimes for uncomplicated vulvovaginal candidiasis. Intravaginal agents, that is, we use the butoconazole 2% cream 5 gram intravaginal for 3 days, or clotrimazole 1% cream 5 gram intravaginally for 7 to 14 days, or clotrimazole 100 milligram vaginal tablet for 7 days, or miconazole 2% cream 5%, that is 5 gram intravaginally for 7 days. Oral agents, fluconazole 150 milligram oral tablets, 1 tablet in single dose. Now, in complicated cases, recurrent vulvovaginal candidiasis usually defines as a 4 or more episodes of symptomatic VVC in 1 year, affects a small percentage of women, that is less than 5%. The pathogenesis of the recurrent vulvovaginal candidiasis is poorly understood, and majority of the women have no apparent predisposing or underlying conditions. Vaginal culture should be obtained from patients with recurrent vulvovaginal candidiasis to confirm the clinical diagnosis and to identify unusual species, including non-albicans species, particularly Candida glabrata. Recommended. Number 1 is longer duration of initial therapy, for example 7 to 14 days of the topical therapy, or 100 milligram, 150 milligram, 200 milligram oral dose of fluconazole every third day for a total of 3 doses, that is day 1, 4 and 7. Maintenance regime, oral fluconazole, for example 100 milligram, 150 milligram or 200 milligram dose weekly for 6 months is the first line of treatment. In complicated cases, severe, compromised and in pregnancy, severe cases, extensive vulvar erythema, edema, excoriation and fissure formation is associated with the lower clinical response rate in patients treated with short courses of the topical or oral therapy, either 7 to 14 days of the topical azole or 150 milligram of fluconazole in 2 sequential doses. Second dose 72 hours after initial dose is recommended. Compromised host. Women with underlying debilitating medical conditions, for example, those with uncontrolled diabetes or those receiving corticosteroid treatment, do not respond as well as to short-term therapies. Efforts to correct a modifiable condition should be made and more prolonged, for example, 7 to 14 days. Conventional antimycotic treatment is necessary. Pregnancy. During pregnancy, VVC frequently occurs. Only topical azole therapies applied for 7 days are recommended for use among pregnant women. I end this part 1 with this. Till now, hope it will freshen your knowledge, and malignant vaginal lesion I will include in my next lecture in the part 2 of the diseases of the vagina.